Uh, Tonight we're going to talk about informed consent, raising smarter, better informed users of our healthcare system. And boy, is this a time more than ever before for us to really understand how to intelligently work with our healthcare system. And really, when JC called me to talk about Dr. Dolan and to encourage me to be on her webinar, to invite her on our webinar, I was like, well, this fits perfectly in what we're doing. First of all, JC is a very difficult person to refuse in the first place, but even then, he still came up with a very good point, because we've hammered these things in most of our webinars. We've hammered these what we call the 4 fundamentals of healthy living. We talk about a good mind. We talk about the good kind of foods plus nutritional supplementation. You cannot get enough of the nutrients from food alone. It doesn't matter how well you try. You just can't get the best nutrients from food. And of course, having a good, healthy lifestyle, which would include exercise, working at something you love, abstaining from excess alcohol, of course, smoking. But number 4 there is especially as you grow older, you have to understand that you're going to be using the healthcare system a lot, not just for the medications, but for even just the routine tests that you do. And there are perils involved in these routine tests, and Dr. Dolan is going to go ahead and explain all that to us. And without much further ado, we're going to hand it over to JC and have JC introduce her. Are you there, JC?
Uh-oh.
Have we lost him?
I think.
Dr. David, I'm here.
Yes, sir. Okay, go ahead.
I tell you what, we are in for it. You having said that this is primarily for healthcare professionals or the layman, we've got a number of doctors on tonight, and we're excited about that from all over the country. And I had the privilege of having dinner with Dr. Dolan here recently, and I am so thrilled that she's on tonight. And we are in for a real treat, and I don't want to take up a lot of time, but she is director of the Medical Accountability Network, and what she is bringing us tonight can very well play a major role in the paradigm shift of healthcare. And I'm excited about that, so welcome aboard tonight.
Well, thank you very much for organizing things, Sherry and Dr. David, and thank you for your gracious invitation, J.C. Spencer. This is a presentation that is something that I really hope changes the way physicians, results and changes the way practitioners actually practice. And definitely I hope that at the end of this presentation, anybody who's ever been in a position or going to be in a position of being a patient really undergoes some significant changes in how they are actually interacting with healthcare professionals. Can I just ask you, Sherry, about the screen? Is it showing up correctly there?
I'm not seeing your screen yet. I have given you slide control.
Sherry, you gave it to JC, not to her.
Okay, so I'm going to clean screen. And
no, I gave it to.
Great. We see your screen now.
Okay, good. Okay, good. So this is a new role for healthcare consumers. Now, why is this necessary? We can all see that in the past couple decades especially, there's been a dramatic change in how we interact with physicians and how physicians interact with patients. In fact, these days, it's really a rare patient who counts his family doctor as his friend, and many even wonder if their doctor has their best interests at heart. And this is a dramatic change from how it was, let's say, in a couple generations ago. And so not only are there a lot of factors bearing on the patient and how the patient sees the doctor, but there's a lot of influences that are on the physician, totally aside from their scientific training. There's, the business aspects of reimbursement. There's this kind of legal atmosphere that we operate in. But what we're really going to talk about here is the things that we can really manage, the things that we can do something about. We may not be able to do anything about the insurance system or the legal atmosphere, but we can certainly do something about in the patient's, in the room, doctor-patient relationship, and that's what we're going to be talking about here. This whole talk is based on informed consent. Now let's go ahead and get into that in more detail regarding informed consent. And, oh, that's me. Not the best picture. I'm usually not that harsh looking. Okay, so what is informed consent? Now, even though this is something that is mandated by many state laws, and there's federal guidelines and medical specialty societies that require it. Even physicians sometimes have a misunderstanding on the meaning of this phrase, informed consent, and most patients never even heard of it. Informed consent is the process of obtaining a patient's permission for a procedure or, in fact, a medication after the patient and doctor have discussed the risks, benefits, and alternatives of the procedure and the patient understands them, emphasis on understanding. So this is an example of what informed consent would look like. How many people have ever really had it? So we look at why, some other definitions of this. Except in the case of an emergency, a doctor really is supposed to obtain a patient's agreement to any course of treatment, not just treatment, but also tests and procedures. They're required to tell the patient anything that would substantially affect their decision. Such information typically includes the nature and purpose of the treatment, its risks and consequences, and the alternative courses of treatment. That does not mean the doctor has to be an expert in all known alternative courses of treatment, but he can at least say, I don't know, for instance, of the benefits of megadoses of vitamin C, and at least not pretend that what he's offering is the end-all of anything potentially to treat this condition. Now, the important part of informed consent is it has to be, the medical information has to be understandable by the person, and they have to be voluntarily giving their consent. Now, we look at why this is necessary. Well, you can take a look at this quote here. There are only two classes of physician, namely those who kill their patients and those who allow them to die. Now, admittedly, this was actually at the front leaf of a book written by a physician back around the turn of the century. And this unnamed French satirist, I've looked far and wide to find out who actually said this, and I can't really get a name to it. But it still remains today that, face it, folks, we're just practicing. It is not a priesthood. There are gradients of how expert we are in different areas, and it's a very rapidly changing science. So the best we can do is practice informed consent. There's estimates that there's more people that die from medical intervention, whether it's surgical or medication-wise, than anything else inside of a hospital. Now, that's probably that number. That estimate is open to debate, but certainly the numbers have been going up and up and up when we see what we call iatrogenic or treatment-caused demise, death. Let's take a look at years past, some vintage ads here. Here's an ad for a cough remedy from the Bayer Company, who later on brought you aspirin. So you can see that our idea in the past of what was an effective treatment ranged all the way to heroin, cocaine. In fact, 7-Up initially had lithium in it, which we know to be a very dangerous medication. Mm-hmm. Here's an example from more recent times. This is a circa 1964 label of a medication called Delicid, put out by Sandoz Pharmaceuticals from Switzerland. Delicid was the patented name for LSD. This was actually a prescription medication from 1948 to 1967. And it had 3 indications, and I've highlighted here the second indication. By taking Delicid himself, the psychiatrist is able to gain an insight into the world of ideas and sensations of mental patients. In other words, here they were therapeutically giving a drug, intravenous or liquid drops under the tongue, that they knew caused insanity. But it was actually used on mental patients. Mm. So again, bringing up more to present time, let's take a look at the fen-phen tragedy. This was a diet pill that was on the market for more than 20 years, a combination pill. When the components of this combination pill, the adverse effects of it were very well known. Most of the adverse effects, some of the adverse effects were not well known by the public or by doctors who were prescribing this diet pill, but they were very well known and documented by the manufacturers of fen-phen. And it was information regarding heart toxicity on the heart valves and the pulmonary vasculature that didn't come to light until lawsuits were well underway. It has now been estimated that nearly 100% of people who took fen-phen for more than 4 weeks have suffered some type of anatomic damage to their heart valves or pulmonary vasculature.
Oh, my goodness.
And about 750,000 people so far have come forward to, be part of lawsuits and to claim some compensation that can document that they've had damage from fen-phen. The interesting thing about fen-phen, as we'll find with many medications, is the adverse effects of these drugs were very well documented even before they came on the market. Once they came on the market, reports of adverse effects really piled up, and even deaths were being recorded long before there was an investigation. Investigations, and in the case of fen-phen, lawsuits had been going on for years before the drug was removed from the market. Another example from the 70s, the Dolan Shield, which was an intrauterine device to prevent pregnancy. Again, there is documentation in the records of the company who made Dolan Shield that there was concerns in-house of the potential for the way this was designed to actually promote the development of pelvic inflammatory disease and severe infection that would cause abnormal implantation of a fetus, but also cause scarring and hemorrhaging and perforation, actually poking a hole in the uterus. And these concerns were well documented even before it went on the market. Like fen-phen, the Dolan Shield suits were going on for years before it was removed from the market. Baycol is one that's a little bit more recent, a cholesterol-lowering medication that was notorious for causing kidney failure and death. There were some 50 deaths before Baycol was taken off the market. Sister drugs in the same class called statins then took, their companies took out full-page ads in leading newspapers to suggest that patients ask their doctor about switching over to their safe medication. Those companies later got fined by the Food and Drug Administration for taking out ads that implied that their drugs did not do the exact same thing that Baycol does, namely cause kidney failure. So let's take a look at some recalled drugs. Fenfluramine, one of the ingredients of the fen-phen diet pill, was on the market for 24 years before it got withdrawn. And again, nearly 100% of people who have taken it now have heart valve damage. Pemeline for 30 years. These are all the, most of these are the generic names here. Seldane, an allergy medication, was very popular. It was on the market for 13 years before it was withdrawn. Encanide was a drug that was given for abnormal heart rhythms, and it was found out that it actually caused more fatalities from abnormal heart rhythms than it saved. Tismanol, on for 11 years, another allergy medication. Some antibiotics are in here. Propulsid, a stomach medication, was on the market for 7 years. So just because something has FDA approval does not really imply that it's safe or, in many cases, even effective. And here we see Baycol was on the market for 4 years before it was taken off in spite of mounting kidney deaths. Of all these I have listed, only Raplan, which is an anesthetic agent, was voluntarily withdrawn. The one at the bottom of the list there, Rifaximin, that's Vioxx, was on for 5 years, with well-documented 4- to 5-fold increase in the incidence of heart attacks in people who took Vioxx, even for years before it was taken off the market. A more recent one here at the bottom of this slide is Zelnorm, which was a stomach medication that affects the serotonin receptors, very much related to the drugs Paxil and Prozac. We find serotonin receptors in the gut and on little cellular elements called platelets. We find it in heart tissue. We also find it in brain tissue. But this Zelnorm had such profound side effects. However, it was still on the market for 3 years before it was withdrawn. So thus the necessity for informed consent. Now we really take a look at the elements of informed consent and where it came from. Really like what's the history of this? What regulates what has to be said and told in informed consent? So let's take a look at the components. First thing is, what is the recommended intervention and how does it work? In other words, we would say medically, what's the mechanism of action? For instance, some medications are being advertised to help with hot flashes. but all we know is that they affect serotonin. Well, we don't really know any direct correlation between serotonin and hot flashes. In fact, we know precious little about what even causes a hot flash. So oftentimes it's necessary as part of full informed consent for the physician to admit, look, we know this has something to do with such and such body chemical, and we're giving it for this problem, but we have no idea how it works. A case in point, nearly all of the drugs that are used to treat mental conditions carry on their labels, on their what we call package inserts, obviously too much information to fit on a label, that the mechanism of action is entirely unknown, but only theorized or hypothesized to be such and such. Second step of informed consent, what is the indication? And by that we mean, what is it FDA approved in order to treat? And this might not just be the name of a disease. For instance, there's some medications that are approved to treat bipolar, but they're only approved for people who are 18 or over. They're not approved for use in children. So the diagnosis may fit with the FDA approval, but the age group may not. There's some drugs that shouldn't be given to the elderly, for instance. The antipsychotic medications have a black box warning against being used in elderly, but they're approved for psychosis, but not for the elderly. So you want to look at, is this drug you're giving me, doctor, approved for the condition for which you're proposing to give it to me? There's a new medication out now called Pristiq, which is desvenlafaxine. It's a second-generation Effexor type drug, and it doesn't have approval to treat menopause symptoms, but it's being widely prescribed to treat menopause symptoms. So part of informed consent for that particular medication would be the doctor telling the patient, one, we have no idea of the mechanism of action. We don't know how it works. Two, it's not been FDA approved to be found safe or effective for your condition. And this would be part of informed consent if it's given for that indication. The next thing is what is known and not known about the safety of the medication. Now here, people have the misunderstanding that just because something was approved by the FDA, it means it's safe. Now all that means is it passed the minimum number of tests that the FDA requires, and the studies that the drug company paid for in a select population that they submitted to the FDA showed an acceptable amount of side effects or an acceptable degree of deaths or injuries from the drug. It does not necessarily mean that it's really what the average person would consider is safe. In fact, many medications, especially in the last 10 years of what we call fast-track approval, drug companies can now actually pay a user fee to the FDA in order to get their drug approval process expedited through the FDA. So we call this fast-track approval. With fast-track approval, we have many drugs that are only tested on less than 300 people and for a year or less. Now, you take that, and it's, yes, it's FDA approved, it passed their muster, then it gets out into the general population where people are of all different age groups. It's being used for things it's not necessarily approved for, and they have other drugs on board, and we see what we call a phase 4 study. A drug has to get through 3 phases of studies in order to be passed by the FDA. Phase 4 is when it's out in the general population, and you're the guinea pig. In the first 5 to 7 years that a drug is being taken, it's a phase 4 experimental study. And that has led some consumer groups, such as Public Citizen, to advise that nobody accept a prescription for a drug unless you have a life-threatening illness if it's been on the market for 7 years or less. So sometimes the far more important portion of informed consent on step 3 is the doctor saying, look, it only was studied on less than 300 people before it was FDA approved. It's only been out for a year. We don't know a lot about its safety. The next step would be what's known and not known about its effectiveness. Is it really effective for my condition? So I'm going to give you a couple of examples here. Let's take isotretinoin, also known as the brand name Accutane. Wouldn't it influence a person's decision somewhat if he knew that the relapse rates it's given for acne, the relapse rate for acne requiring retreatment with this expensive drug that's toxic to the liver range from anywhere from 20 to 50%. that may or may not influence somebody's decision as to whether they're going to go on the drug. It also has a lot to has now a black box warning regarding depression and potential suicide. So knowing that the drug may only be 50% effective, may require retreatment, may really influence somebody's decision. Another example, people might not be so eager to take oseltamivir, also known as the flu medication, Tamiflu, if they knew that the manufacturer's own studies only show that it reduces the flu symptoms by 1.3 days. And then only if it's taken within the first 24 hours of symptoms at a cost of over $80. Now, that is what's actually written in the manufacturer's information if you care to read the 6-point font, 50-page package insert regarding Tamiflu. But if you actually just take a look at the New York Times from the month of January, you see that the Center for Disease Control has found that this year, the flu strains that are going around this year are 99% of them are resistant to Tamiflu.
Mm-hmm. Mm-hmm.
And when Tamiflu, when it worked, it only was effective by shortening the symptoms by 1.3 days. Still on the flu, we look at the flu vaccination. That's an interesting one. In the lab, it definitely decreases infection. It definitely decreases infection by flu. And actually, in people in experimental studies, they will not get the flu if they are vaccinated with the appropriate vaccine, for the flu strain that's going around that year. However, in the broader population, vaccinating against flu does not at all decrease the amount of what we call influenza-like illnesses, days lost from work, from flu illnesses, or deaths from influenza-like illnesses. Now, when we have a flu season, the vast majority of people who are getting sick aren't getting what's really influenza virus. What they're getting is flu-like illnesses, and you'll hear people say, oh, I was down with the flu. Well, the vast majority of people don't actually have influenza virus. They've got what's called an influenza-like illness. And when you take influenza-like illnesses all told together, the flu vaccines don't decrease it, and overall they don't decrease the amount of time lost from work. So this would be part of a doctor explaining what's known and not known about its effectiveness. The next step would be to discuss what are the alternatives to treatment, including the consequences of no treatment. Somebody comes in with a sore throat. It may or may not be strep. Let's say they don't get tested for it, which is ridiculous. It's about a 50-cent test. Everybody should be tested. But let's just say they say, well, the person says, I'm getting ready to go on a trip and I don't want to be sick. Can I have antibiotics anyway? And the doctor should be obliged at this point to say, look, it doesn't look like it's strep throat. You can really do just as well with some hot tea and some vitamin C. On the other hand, if it does look like strep, they should say, look, you have a certain definite chance of developing rheumatic fever if you fail to take a course of penicillin for the entire 10 days. So the alternatives to treatment, including the consequences of no treatment, but in these days of massive over-treatment, a lot of times an honest part of informed consent would be to say, you know what, chances are you're going to get better if we don't do anything. Now, another part of informed consent is to disclose conflicts of interest. And this is something that the state of Massachusetts has led the way legislatively by actually requiring this. Texas, where I'm at, actually has a bill under consideration in the legislature to also require physicians to disclose conflicts of interest. And we'll discuss later that Pennsylvania has such a law. Even if a physician refers somebody to a pharmacy down the street, if he's got a partnership or he's going to get some money back from the pharmacy, he's required to disclose it. This might make a very big difference in the person's evaluation of the trustworthiness of the data from their physician, and they deserve to have that information. I mean, we get it when we make major appliance purchases, when we undergo legal contracts and things like that. So let's take a look at the background of informed consent. People have heard of the Hippocratic Oath. There's a misunderstanding. Some people have a misconception that all doctors at some point or at the end of their training stand up and hold up their right hand and take this oath. Well, I went to University of Illinois Medical School up in Chicago, which is the largest medical school in the country, and we didn't take the Hippocratic Oath. And in fact, many people, many doctors don't even know what the Hippocratic Oath consists of. It's commonly said that it consists of first doing no harm. But in fact, it was initially an oath to the pantheon of gods, and it has had several components to it. Among other things, it says, I will not perform an abortion. It also says, I won't have sex with my patients. And it has been modified throughout the years, and the prohibition against abortion has been taken out. The prohibition against sex has been modified. But it doesn't include first do no harm. What it does include is this statement: I will neither give a deadly drug to anybody who asks for it, nor will I make a suggestion to this effect. Well, how do you practice modern medicine and adhere to this oath? And the best we have is informed consent. Well, look, I'm going to give you this drug. I think the benefits are going to outweigh the potential bad effects, but the person has to be informed of the potential bad effects so they can make a decision as to whether they want to accept the drug. After that, come up to the last century, and we come up to the Nuremberg Code. Now, some people may recognize that this came out of the legal action that was taken against 23 physicians and administrators who were working for the Nazi Party in the name of medical science during World War II. This is, they basically had a political agenda, but they were carrying it out on the pretext of medical treatments or medical research, and it included eugenics, euthanasia, and medically justified experiments, sometimes very thinly medically justified. So this court, which was presided by American judges, heard 85 witnesses and examined over 1,500 documents. And they looked at crimes that were committed in the guise of medical treatment as part of so-called acts of duty during wartime. And they concluded that the program was criminal, and the medical experimentations were taking place were always conducted without consent, of course, and they were often deadly, and if not deadly, they were often crippling. So what does this have to do with modern-day informed consent? Well, the Nuremberg Code grew out of unethical medical treatments that were administered by force and coercion under the guise of medical necessity. So it's not really a guide for research institutions. What they did is they not only found these doctors and administrators guilty, they came up with a code of conduct, some principles that said this is how medicine should be conducted, and it's the basis of our modern-day informed consent. Now, again, what does that have to do with the doctor-patient relationship? I'm not a prisoner when I go to the doctor. On the other hand, I'm a prisoner of ignorance. Patients are often prisoners of ignorance. They hear about something on TV. The doctor's writing with a pen that has the name of the drug emblazoned on it. He's writing on a prescription pad that's got the logo of the drug company on it, or some notepad that does. He's drinking from a coffee cup that says the latest, cholesterol-lowering medication. And there's coercion that's more subtle these days. So yes, maybe it's not politically mandated and it's not a Nazi regime, but the Nuremberg principles still hold. The person has to be told of what the expected outcomes of the treatment are and what are the known risks and benefits before he gets a medication. And this is really the basis of all medical malpractice suits. I did not know, you did not tell me that it was going to have that effect. So the Nuremberg Code says that the person should have sufficient knowledge and comprehension of the elements of the subject matter involved so he can make an enlightened decision. Then we come to a uniquely American document, the Belmont Report. And there was an act of Congress in 1974 that created the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. They met at the Smithsonian Institution's Belmont Conference Center, thus Belmont Report, came out about 4 years later. And it's a uniquely American informed consent code. It says that it's the first informed consent code that really also addresses mental treatments and not just physical treatments. And it calls for informed consent in everyday practice settings, not just in traditional research environments. It really emphasizes that the patient should be given adequate information on risks and benefits, and really strongly hits on this point of the information has to be understandable by the recipient. If it's not understandable, if it's a bunch of medical mumbo-jumbo, or if it's dumbed down too much, you can't say that they really had an opportunity for informed consent. It also really specifically defines the practice of medicine. By that they mean things that are really designed to enhance the well-being of the patient as opposed to research, which is sort of looking at the greater good and maybe not necessarily for that individual. So violations of the Belmont report have actually been cited in malpractice cases where somebody was given a drug off-label, meaning drug was FDA approved, but not FDA approved for the condition that the doctor was prescribing it for. And so that was essentially giving somebody a drug that's experimental, and you haven't told them that you're giving it, quote, off-label. So the Belmont report has been cited as the basis of successful suits in that regard. There are guidelines and rules and regulations that really monitor informed consent. The one that most doctors are familiar with is the American Medical Association Principles of Medical Ethics. But it's very vague. It just says that the doctor should make relevant information available to patients. Now, what a lot of people don't realize is only some 26% of physicians in the United States are even members of the AMA. And really? Yet the American Medical Association codes are so well recognized that in lawsuits they are referred to even if the particular physician is not a member of the AMA. The American College of Physicians has a very detailed informed consent guideline, and it really emphasizes that the communication regarding the drugs and the medication of the proposed test or treatment should be really understandable by the patient, not medical mumbo-jumbo. The American College of Surgeons has the most complete informed consent guidelines, and they're very simple. They're everything you'd want to know. You know, why do I have to have an operation? What's the alternatives? What happens if I don't have the operation? What are the basic procedures? What are the risks? How is it going to help me? How long am I going to be in the hospital? How long is it going to take to recovery? When can I get back to normal, activities? And what would be the residual effects of the operation? Now, the American Psychiatric Association has one of the most extensive ethics guidelines of any specialty society, and obviously the mentally afflicted or emotionally unstable patient is one of the most vulnerable to coercion and undue influence. But ironically, informed consent is only briefly mentioned in the addendum section of their ethics guidelines. And it simply states the profession, quote, rigorously preserves informed consent. So this is really an area that gets a lot of attention by human rights groups and by the legislature, because this is the most vulnerable population. They actually have the worst basis of informed consent guidelines. Now, when we look at state licensing authorities, the organizations that allow doctors to have their license, Texas, my own state, has the most detailed of informed consent rules. And you not only have to say what the side effects of a procedure or a test or a drug would be, you have to say what are the reasonable alternatives to what you're offering the patient. You have to inform them of the risks and the benefits of various treatment options. But unique to Texas, you also have to discuss with the patient the diagnosis and what is the evidence for your diagnosis. So when we have these new diseases like fibromyalgia, chronic fatigue, restless leg syndrome, other vaguely defined diseases such as bipolar, any number of the new diseases or diseases that are defined by checklists of symptoms rather than real anatomical pathology, it's really a challenge for the physician to give full informed consent in Texas, because what is the evidence for the diagnosis? In other states, they don't have such detailed informed consent laws, but Illinois has a specific statement about no human experimentation using unproven treatments. And again, this has been used successfully in lawsuits when people were given a medication they didn't know it was off-label. The drug was approved for something else than what the doctor gave it for. There's nothing illegal about that. What's illegal about it is the doctor not telling the patient that I'm giving this to you even though it hasn't been FDA approved for what you have. And some estimates are up to 40% of prescriptions are given off-label.
Wow.
That's basically human experimentation. New York has an injunction against guaranteeing any cures under no circumstances, no matter what the treatment. You cannot guarantee that you're going to cure somebody in the state of New York. Illegal. This has actually been used to stomp on people who are providing alternative treatments. They're saying, you're saying that you're curing something against the law. Wisconsin really emphasizes the need to tell the patient about alternatives. And again, the most honest thing for a physician to say here may be, I don't know of the alternatives, or I don't know how viable they are. In many states, just carry what's called the Patient Bill of Rights, which just generally says you have a right to know about the risks and benefits of your treatment and doesn't really go into a lot of detail. There are, other states sometimes just address very specific things like abortion, informed consent for abortion, or HIV testing, informed consent for the use of stem cells, informed consent for the use of electric shock. Pennsylvania is one where you actually have to reveal your conflict of interest in facilities you refer to, like a place that does an MRI down the street. Oh, I get a kickback from them, a legal kickback, or I have an investment in the pharmacy down the street. But many just address informed consent as it relates to very specific conditions rather than having a general informed consent law. Now, there are lots of influences on treatment recommendations that can sort of pollute the atmosphere between patient and doctor and keep really effective, thorough informed consent from happening. And if you really trace these down, these influences, they all go back to the almighty dollar. When we look at what is really controlling or monitoring the content of drug advertising, we have to go all the way back to the turn of the last century when the Wiley Act was made, and it actually formed a new agency called the Federal Trade Commission. Now, this didn't have anything to do with protecting patients. It was simply a law that was passed to protect a company from unfair advertising by a competitor. Had nothing to do with patient interest. In 1938, the FDA was formed, and their sole job at that time was to monitor claims on drug labels, whereas drug advertising remained with the Federal Trade Commission, the monitoring of drug advertising. In 1951, the Durham-Humphrey Amendments came to the Food and Drug Administration Act, and they made a distinction between which drugs could be given over the counter and which were so hazardous that they required a prescription. And the idea there was drugs that require a prescription is the responsibility of making sure it's the correct drug and that the benefits outweigh the risk was really on the shoulders of the physicians. In 1962, the Kefauver-Harris Amendments called for the FDA to oversee drug advertising in addition to just drug labeling. But this advertising was so far only to physicians in medical journals. It wasn't out to the general public. In 1981, there was no prohibition against advertising directly to the public, so that was when we saw our first direct-to-consumer advertising. The company that made ibuprofen at that time ran some ads for their arthritis drug, and then Merck followed with ads for the pneumococcal vaccine. But there was so much controversy over these that it prompted the FDA to have make a moratorium on drug ads for a couple of years until they could figure out, well, what should the guidelines be? Well, the ban was lifted in 1985 when they said, these direct-to-consumer ads have to say all the information about risks and possible side effects, the same information that is present in medical journal ads, the same information doctors were getting. Well, you saw a real decrease in direct-to-consumer ads after that because it was so expensive. They spent the majority of the commercial at hyper speed, saying it could cause your head to fall off and your arm to wither and to go blind, etc., because they were required to essentially say nearly all of the potential adverse effects. Well, that got modified in 1985, and they said, you really only have to convey the most important warnings and the most important side effects and precautions. And ads had to be, quote, fair and balanced. But unfortunately, nobody was monitoring it. And as anybody can see, the ads paint a very pretty picture even today, and really don't mention even 5% of what you can find actually in the package insert. In 1997, consumers were dealt another blow because the disclosure requirements were further modified and even made more lenient. And that 1997 is when we saw the real takeoff of drug ads. Now I'm just going to show you some vintage ads. These were from medical journals before ads went directly to the consumer. But this is where Madison Avenue cut their teeth on drug ads, was in the journals to physicians. This is an ad from around the 1950s for, I believe it's Valiant. No, it's an amphetamine. Why is this woman tired? The small print says, well, one of two reasons. Okay, she's either overworked or she needs an amphetamine. No, I don't know. Look at those dishes. I'd say she's overworked. Here's another ad. This is for Valium. It shows a photo book of this person, Jan. Here she is with Dad, and then she's with some of her friends, and there's Joey, and then she's with Ted, and then she's with Dad again, and there's her brother, and she's with another guy, and then she's with Dad again, and here she is, 35 years old, on a cruise by herself. Picture there, Jan, 1970, in the lower right corner. 35, single, must be psychoneurotic, needs Valium. Here's another one. This is where they started really treating normal life situations as mental illness. This is, a situation where, here, this is supposedly a divorce paper. Oh my God, she needs Ascended. Excessive use of the telephone. Does anybody have a BlackBerry or a Bluetooth? Well, might be chronic neurotic anxiety. You better get a powerful tranquilizer there. So this is where they cut their teeth on the ads. Now, the direct-to-consumer ads can either be so-called help-seeking. If you have stiff joints, ask your doctor about a new medication where they don't mention the medication. Reminder ads give the name of the drug, but they don't really have any details about its use. But it's the product claim ads that give you the drug's name, tell you what it's used for, and tell you how great it works. And it's those ads that are supposed to tell us what the side effects are. They require disclosure of the adverse drug effects. They're supposed to convey all the important things, and it's supposed to be fair and balanced. But nobody's really paying attention, and any poll of physicians anywhere can show you that it's not fair and balanced. Well, so these lighter restrictions on having to say all the risks of an ad really caused an explosion in direct-to-consumer advertising. We look at how many, now this is in millions here on the left side of the page. This is millions, okay? So $4,500 million were spent in 2005. And this was from a Government Accountability Office report titled Improvements Needed in Oversight of Direct-to-Consumer Advertising. And here's the same data in a different format. I mean, just an explosion. We're talking billions. And what has this gotten us? Well, it's really convinced people that there is a pill for everything that ails them. In a time period when the population only increased by 9%, there was a 71% increase in the number of people taking a prescription drug.
Good marketing.
Yeah. Now, if we compare what's spent on direct-to-consumer advertising to what's spent on research and development of new drugs, and we just take that time period from 97 to 2005, direct-to-consumer advertising spending jumped up 20% more each year. Giving drug promotional materials to physicians went up 9% every year, whereas spending on research and development only went up 9% per year. Now I'm going to spend a little time on this busy slide because it's very revealing. They have done many surveys and studies looking at how do physicians respond to direct-to-consumer advertising and how does it affect them. Well, supposedly 40% of doctors feel that these ads have a positive effect, and 2/3 said, hey, it helps to educate patients. However, 4/5, 80%, said that these ads encourage patients to seek out treatments that they don't need. 1/3 felt that these ads had a negative impact on their practices and that it made their patients less confident in their own judgment. Hey, TV says that I need such and such, and the doctor's gone, I don't think that's a good idea. Well, they go doctor shopping. And you don't really have to doctor shop very far where you find somebody who will give you anything you demand.
Right.
More than 80% felt that the ads did not provide information on the risks and benefits in a balanced manner as they're required to do by the FDA ruling. Now, here's an interesting thing. The physicians claimed that they only prescribed an advertised drug in 39% of visits, and this is where a patient saw an ad on TV, came in and said, I want the purple pill. And the physicians claimed, well, only less than 40% of the time did they go, okay, I agree, I think you need that. But when they did another study that really looked at, aside from what doctors think they're prescribing or not prescribing based on patient demands and commercials, what really happens? Well, what really happens is more than 80% of the time they're actually prescribing a drug against their better judgment. And the way these studies were done, they actually had physicians, they had patients who came in, they interviewed them in the waiting room. Oh, yeah, I saw an ad for such and such, and I'm here for such and such pill. The person would go in with a urinary tract infection or depression or something and say, I want X medication, and the doctor would prescribe it, and then they would interview the doctor later and they say, what's the best drug for urine infections, or what's the best drug for infection? And they found that the majority of the time the doctor had prescribed something different from what he considered the best medication for the person, or that they prescribed something when they really didn't think that the person's condition required a medication at all. It's profoundly influential. This direct-to-consumer advertising and patients' demand of medications is profoundly influential on doctors' prescribing habits.
Contrary to what they think.
Yes, contrary to what they're reporting, their impression of how much it affects them, correct. Now, American College of Physicians testified to Congress on the effect of direct-to-consumer advertising, and they said these ads leave patients confused, and worse yet, it leaves them profoundly misinformed. But totally aside from the ads and the effect of patients demanding something from the doctor, there's this whole other area of advertising to healthcare providers that's very big business. And it's based on freebies. Now here I'm showing you a steak dinner, but the main freebie is stocking the doctor's office with sample medications. This is a very effective way to get them to prescribe drugs. Oh, the person has such and such condition. They may not think that the drug that they have in their sample cabinet is the best one, but hey, they've got samples of it, so they give it to the patient. The patient then subsequently demands the drug, or they simply get into the habit of writing for that drug. So long after the free samples are gone, they're still prescribing, and usually these are the newest and most expensive, and they've been out the shortest length of time, so they have the most sketchy safety record of any medication that they could possibly pick. Now, this is really bad business, this advertising directly to doctors, because studies have shown that when, for instance, an office, or more particularly, there's been studies showing when a medical school has an open-door policy for any drug sales rep that wants to come in and stock the medical school clinics with free medications, give the medical students stethoscopes, provide pizza while they're giving them a presentation on their drug. When a medical school has an open-door policy, they statistically score significantly lower on their National Medical Board exams compared to medical schools who don't have an open-door policy to drug reps. In other words, the doctors are getting false data. Now we're going to talk a little bit about the manufacturer's promotional material actually to physicians. There was one study that showed that when they looked at all these glossy brochures and excerpts from medical articles and quotes or charts that are extracted from supposedly medical research all compiled in these glossy advertising brochures that the drug reps stuff doctors' offices with. It was found that they did a comprehensive survey of over 130 brochures. Only 6% of the claims on these glossy brochures could be verified. I mean, sometimes there was actually references to journal articles that were non-existent. Other times they found the journal article, but it said something completely different than what was stated in the glossy brochure, but they used that article as a reference. Other times they found just distorted data. In order to make something look more beneficial, they stretched out the y-axis compared to the x-axis on a particular graph, let's say, to make it look more effective than it really was. So they took the article's numbers, but then made a false representation of how effective, let's say, it was, or how few side effects it had. Wow. So the manufacturer promotional material, and sometimes that's all a physician claims he has time to read, that's where he gets his drug information. Drug companies also are sponsoring more than 2/3 of continuing medical education inside medical schools or out in the community. They're big sponsors, either medical device manufacturers or companies that are actually selling drugs, big sponsors of drug continuing medical education. In fact, it's hard to find a conference to go to that doesn't have drug company sponsorship. And I just want to say, Dr. David, that's one of the real refreshing things about these Building Strength webinars, is no drug company influence.
Yeah, we're going to keep them out.
It goes beyond that. The medical journal articles, if a doctor does take the time to even read his journal articles, they are so dependent on the drug companies for advertising revenue that it really influences their ability to objectively really edit these articles and really scrutinize them for reporting falsely. And one way something can be reported falsely but still get through an editorial board is they could just exclude all patients that had side effects and then just continue the study with the people who didn't get wiped out in the first 2 weeks on the new drug, for instance. Or compare a new drug to an old drug but underdose the old drug, so it is intentionally made to look like it's not working as well. When they're doing a study to show side effects, maybe overdose the old drug, so it will intentionally give more side effects, underdose the new drug, showing, well, the new drug has fewer side effects. And this type of activity, which is routine, and it's not just routine with what we in medicine call the junk journals, it's routine in the brand name journals, the New England Journal of Medicine, the Journal of the American Cardiology Association, the Journal of the National Cancer Institute. It led Richard Smith, editor of the British Medical Journal, for 25 years to make this amazing statement with no qualifications. Medical journals are an extension of the marketing arm of pharmaceutical companies.
That is scary. That is scary. Does the FDA know about this?
Well, the FDA doesn't have any jurisdiction over medical journal articles whatsoever.
So who does?
Well, it's an honor system. Again, people have, come to trust these bastions of academia and these, astute organizations, and they have their editorial boards. But another editor, Marshall Angell, she was the physician who is the interim editor of New England Journal of Medicine, and she is one of the strongest critics of the conflict of interest that takes place in medical journal articles, and you're not going to see her on the editorial board of the New England Journal of Medicine anymore. Now, it goes further, though. There's lots of undue influence taking place in what are perceived as advocacy groups. So we have all these disease advocacy groups, and you would think, well, that's good for the patients. I mean, they want to get research done on their particular disease. They want to get help from these groups. They want funds raised. Let's just take the restless leg syndrome. This is a recent invented disease. They received almost $500,000 of their 2005 budget from manufacturers of a drug that was recently approved for restless legs. And they got another almost $200,000 from another drug company who has a restless leg drug that's still under trying to get approval through the FDA. So we see this so much that these advocacy groups are really nothing more than another marketing arm. Let's get some patients to fill out this questionnaire on restless legs, and overnight, through their own survey, all of a sudden 1 in 10 Americans have restless leg syndrome. I don't know about you, but my legs are getting a little restless right now just hearing it. The New York Times did a report on the Midwest Heart Foundation. Medical device manufacturers, a heart device, were liberally donating to this nonprofit medical group. Well, their generosity was gratified by a study of the company's own heart device and handsome profits for the funded doctors and their academic institutions. Now, their website brags that their foundation gives patients access to medical advances before they come to market. Translation, you're being experimented on, and we're handsomely profiting from it. Another example would be for fen-phen that we talked about earlier. The principal financial support for several advocate groups at the time that fen-phen was being advertised, such as the American Obesity Association, came from fen-phen manufacturers. In fact, they even started up some of their own. The one called American Association for the Study of Obesity was totally a drug company invention. They operated as nonprofits. They sponsored mass mailings to physicians. They got free spots on public service announcements. But what was wrong there is they went well beyond warning about the health effects of obesity. They liberally inflated disease statistics, and they really emphasized drug treatment. Well, you should diet and exercise, but here's a great pill. Back on the restless leg syndrome advocacy group, their website actually is the exact same colors of the packaging of the restless leg syndrome drug. I mean, it's so transparent. Now, another area where there's tremendous conflict of interest, just gross conflict of interest, is in these national advisories. Example, the National Cholesterol Education Panel just one day voted that, instead of the acceptable total cholesterol being 220, it should be 200. Overnight, that made 1 million more people eligible for cholesterol-lowering drugs, and the stocks showed it within 6 months. The stocks of drugs like Lipitor, which is the best-selling drug in the world. And it was arbitrary. The evidence to support that was hotly debated, but it was the National Cholesterol Education Panel. Now, the Center for Science and the Public Interest investigated and found that something like 7 out of 9 people on the panel were directly in the pay of statin manufacturers. Statins are the #1 drugs that are given for high cholesterol. So they defended themselves by saying, well, they're only guidelines. We're not saying people have to take this. So this, unfortunately, is business as usual these days. When we look at what's happening in a doctor-patient interaction, we have the direct-to-consumer advertising really impinging on the patient, and we've got the drug detailing, as we call it, or the drug sales reps impinging on the physician. There's over 90,000 drug sales reps in this country. There are something like 7 pharmaceutical company lobbyists for every U.S. senator. I mean, this is a very powerful machine, and this is what goes into the doctor-patient relationship.
They don't have a chance. They don't stand a chance.
Well, what we recommend for doctors is that they should get familiar with their top 25 recommendations, whether that's a PSA test, a mammogram, or a prescription for a particular medication, and they should really research what's known and not known about the safety and effectiveness and what are the viable alternatives to those treatments. And they should take the responsibility for being an accountable physician by offering the opportunity for true informed consent in lay language. Now, one of the great resources that we have is what the FDA does require has to go in the what we call label, but obviously it's usually a multi-page package insert, and oftentimes you're not even getting the insert when you pick up your drug at the pharmacy. In any case, it's all in language you can't understand, but the physician has access to all of those. And you should demand that you get the facts, and many of the facts just in the manufacturer's information alone can strongly influence your decision and might be sufficient, but obviously you should look beyond what the manufacturer is telling you in order to get a well-rounded picture of safety and effectiveness. So I'm going to give you some examples here. Prozac has right in its FDA-required package insert the little statement that Prozac has never been tested against a placebo for longer than 4 weeks. Ritalin hasn't been tested for safety longer than 4 months. Now,
Really?
a new cardiac warning. Right, stunts growth. I mean, if people actually got true informed consent on what's known and not known about Ritalin, sudden cardiac death with no cardiac history in the family. I personally had to review the medical record of a 14-year-old who died right after he was skateboarding on Ritalin. Had complained of chest pain for 3 days. Well, he was on Ritalin. Nobody really paid attention to the kid. You know, how many people would actually consent to be giving this to their kid for 9 months out of the year if they knew it hadn't been tested for safety longer than 4 months? Lipitor is a really good one. Regarding Lipitor, one of the statin drugs that's used to treat high cholesterol, there's this whole idea of if lowering the cholesterol is good for people in certain age groups, you know, men who are middle-aged who've already had a heart attack, why then lowering cholesterol is good for everybody. It's the one-size-fits-all idea of drug advertising. And it's really a bad idea. Statins are less and less effective as a person gets older, all the way to the point of being statistically useless in the elderly. And yet cardiovascular disease is something that builds up gradually. It gets more likely as we age. So the more likely we have the disease, the less effective something like Lipitor is. So if we really look at Lipitor in people who have what are called high risk factors, cholesterol of 250 or above, and have had a heart attack, just in that category, the study's own, the drug's own package insert actually says that 100 people have to take the drug in this category, you know, the high-risk category, for over 3 years, every day for 3 years, in order to avoid a heart attack in one person. Okay? Now, if people knew, okay, that means 299 of you are going to be taking this drug every day for 3 years, getting the liver tests that go along with it, and paying about $1,400 a year to take the drug to prevent a heart attack in one person, how many people would actually take it? Now, when we actually get to the lowered cholesterol guidelines of now they don't want the cholesterol over 200, and we take people who don't have any other risk factors besides their cholesterol, haven't had a heart attack or anything yet. This is a one-size-fits-all. If it's good for you, then it must be good for everybody. They take that group of people taking Lipitor, okay? If everyone had cholesterol over 200 who took Lipitor, you would have to treat 298 people for 5 years in order to spare a single person from a fatal heart attack. Now, this is called the number needed to treat. Now, if people knew that one life saved out of that many, you know, was what they were in for. But what they're asking their doctor is, hey, is this drug worthwhile for me to take? The national statistics simply don't apply. I mean, we don't put on our seatbelts in order to prevent a car accident in the guy in the next lane.
No.
We're putting on our seatbelts to prevent injury in case we get in an accident.
Right.
So it's not that Lipitor is a good or a bad drug. It might not be for you. If you are given true informed consent based on your age and your sex and your risk factors from your physician, you might have a lot to think about there before you go, oh, Lipitor, lowers cholesterol, must be good for you. Informed consent is also required for procedures. Like I said, the flu vaccination or tests, for instance. The PSA test, the blood test called prostate-specific antigen that people have been doing for years to screen for prostate cancer. Turns out the U.S. Preventive Health Task Force has dropped it from their recommendations because it doesn't predict, a high level does not predict a finding of prostate cancer when it's used as a general screening device. And yet we see ads all over the place of let's get our prostate tested. This is really driven these days by an organization called Us2, T-O-O, and they have a little blue ribbon instead of a pink one, and it's largely funded by the company that makes medication to treat prostate cancer. Surprise, surprise. Bypass surgery is another one. There's an article out in this week's New England Journal of Medicine documenting that bypass surgery is no more effective than a drug-eluting stent, a little metal stent that goes in to open up the artery that's coated with the medication that's slowly released. So cutting the chest open, going on a bypass machine, is no more effective in preventing heart attack or death than getting a drug-eluting stent. However, bypass surgery gives you a much greater chance of having a stroke within 12 months of the surgery compared to the stent. Now, in the stent, you have a higher chance of needing a subsequent heart procedure, like maybe another stent within that 12 months, but you're not getting a stroke, and you haven't gone on a machine, and you haven't had your chest cracked.
Right.
So mammograms is another one. Mammograms do detect growths in the breast when they're much smaller than can be felt on a physical exam. However, detecting the cancer sooner does not result in any prolonged survival. Now, how many people getting a mammogram are told that, yes, we can find a tumor sooner? No, it won't make any difference in the incidence of your chance of falling off the cliff after 10 years. This is because it tends to detect what we call ductal carcinoma in situ. These are the little cancers that aren't invasive into the breast tissue and aren't expected to cause death in any case. So yes, it's showing up more growth, but it's not causing a change in mortality at all.
So if all they did was wait until the growth was large enough for them to be detected by hand or by palpation, that wouldn't make much of a difference than if the mammograph caught it a lot earlier.
Right, because what the mammogram catches earlier is the ductal carcinoma in situ that wasn't going to kill you anyway, and only less than 1% of those become invasive cancers. They're not deadly. They're not deadly growths. Okay. Mammograms, don't have any increased detection rate when it comes to the invasive tumor, so that's why they don't make a difference in survival. What happens, though, is a person is a cancer consumer for a longer period of time, and that's why we find that the founder of Breast Cancer Awareness Month is AstraZeneca, who makes tamoxifen. Other contributors are GE, who makes the mammogram machine, DuPont, who makes the film. And this organization, this whole movement of Breast Cancer Awareness Month, they don't focus at all on causes and prevention. It's all about getting you in and getting you to be a cancer consumer for a longer period of time.
Right.
So this would be ideal informed consent, that the doctor and patient can have an interaction and can discuss a proposed treatment without any influence from the people who stand to profit from you taking the treatment, the test, or the medication. So what you really need as a consumer is to get these questions answered. What is the intervention? What is it? Why do I have to have it? How does it work? What's known and not known about its safety? Does it work? And that's its effectiveness. What are the viable alternatives? Now, we don't expect somebody to know all about Chinese acupuncture, but if it's something that's harmless and a person suffering from something we don't have a good track record of treating anyway, like headaches or back pain, well, yeah, try out some Chinese acupuncture. And finally, what are the conflicts of interest? And these are the essential components of informed consent. There's lots of resources. I'd like to direct you to my website, smartmedinfo.com. There's many other resources. Some of these are more specifically for physicians and for the consumer. By survey, 99% of medical websites on the internet are financed by somebody who stands to profit by you buying something from them. So you really have to demand from your physician these questions on informed consent and really be able to know what to ask and how to evaluate the answer. I could give examples all night on various medications, but at this point I'd like to open it up to questions.
Sure, absolutely. Wow, this has been very, very informative. Gosh, where do we start? Okay, let me start with a few of mine, and then Sherry has typing some right now. Okay, Pap smears, do they help?
Yes.
Okay.
Pap smears can detect abnormal tissue very soon. Now, what you need to be known is Pap smears are graded according to a grading system, and the CIN number 2, about 40% of patients spontaneously go back to a normal tissue. So sometimes there's a real aggressive approach to jumping in there and treating, but the number one thing that should happen if you have a CIN Roman numeral 2 reading or less is to simply repeat the Pap smear down the road. But Pap smears have been gotten the credit for profoundly decreasing the incidence of cervical cancer and the death rate from cervical cancer over the last 40 years. However, the improvement in survival and decreased death from cervical cancers also happened at a time when there was an increased use of condoms. And condoms prevent the transmission of all kinds of things that can promote cancers and abnormal growths on the cervix. So it's hard to tell what's what. It's probably a combination of both. But Pap smear is good for early detection, and early detection in cervical cancer does make a difference. Unlike the HPV vaccine, but I'll only go into that if somebody has a specific question about it.
That was going to be my next question, because Gardasil is something that's promoted everywhere now. So how effective is the HPV vaccine called Gardasil?
That's a good question. Gardasil vaccinates against 4 types of human papillomaviruses. And the reason it's targeting those 4 types is those are the 4 types that are closely associated with cervical cancer. However, there remains very intense debate as to whether the virus actually causes the cancer. And when Gardasil was up for its FDA approvals, there was actually an FDA scientist who voiced a concern about this. That is a concern that a lot of medical researchers have, is what comes first, the chicken or the egg? Is there an abnormal cancer growth and that allows virus to grow, and that's why we tend to find the virus in association with cancer? Or does the virus in fact cause the cancer? This is not a question that's answered. It didn't stop them from getting approval for their vaccine. But what they found is for anybody who has never been infected with those 4 types that the vaccine protects against, it's about 91% effective in preventing infection. Now, in the studies, they didn't go long enough. None of the people who got the vaccine got cancer. But guess what? None of the people who didn't get the vaccine got cancer either. So the studies that they submitted to the FDA and their approval didn't show whether it prevents cancer. What it showed is it might prevent an abnormal Pap smear, and it does seem to prevent infection from those 4 subtypes. But here's the clincher. It turns out that there are over 150 main types of HPV viruses. And among those types, there's subtypes numbering what some think is in the thousands. And there is a legitimate concern that all the vaccine is going to do is push viral shift over to seeing the ones that the vaccine doesn't protect against. We certainly have a lot of precedent for this in other vaccination programs. So, you know, here's what we know about the HPV vaccine. It can prevent genital warts that were due to the strains that are in the vaccine. It doesn't prevent against warts that are due to any of the other strains. If you're already infected with one of the vaccine types and you get the vaccine, it can make the infection much, much worse. And right now we have no routine testing for viruses before you take the vaccine. In fact, insurance generally doesn't pay for that. The vaccine doesn't prevent against any of the hundreds to thousands HPV types that aren't in the vaccine. HPV vaccine, due to the not included types, the girls still got those viruses if they weren't otherwise protected, for instance, with a condom. Now, a condom protects 70% effectiveness against all virus types. You see, whereas the vaccine is 90-some protective against only these 4 types, you see. Now, this was all based on studies that they did in this controlled population. When they looked more at a general population of people who they didn't know what they've been infected with in the past, the effectiveness of the vaccine was only 12%. in preventing precancerous pap smears. 12% effectiveness. It takes 3 doses. It's given over the course of several months, and it costs $360, a 12% reduction, being marketed at a time when the deaths from cervical cancer are already steeply on the decline, either from condoms or pap smears, but probably a combination of both. In other words, we're seeing a repeat of what we saw when the polio vaccine was introduced. Polio was already steeply going away, and then the vaccine was only came into being right at the tail end of polio, already going away on its own. So, the other concern we have on the Gardasil vaccine is the longest portion of the study only lasted just under 4 years. So there's no long-term data on how it affects the ability to become pregnant. And here we're advertising that it's good for girls between the ages of 9 and 16. And we have no idea what it's going to do to their future fertility. There are increasing reports of profound adverse effects, including birth defects and neurologic problems from getting these vaccines. So
Already?
It's something that if anybody undergoes that vaccine, now you have to understand that you're actually taking part in a phase 4 study, which means once it's out in the general population, we see what it really causes. And it's just, in my opinion, it's absurd that some states are actually trying to mandate this vaccine as a requirement for enrollment in school.
Isn't Texas doing that?
They tried to do it. It got shot down, but they're doing it in other states.
Right. Gosh, golly.
And again, there, follow the money. Look at which lobbyists are lining the pocket of your legislators.
Before we ask the next question, could you put up the slide with the websites again, please?
Yes.
Now, this the conception that most people have is that, thank you, by the way, that most people think that the FDA is meant to assure that all our drugs are safe and effective. What do you have to say about that?
Well, the requirements to pass FDA muster have just been getting watered down and watered down and watered down until, like I said, some drugs, like, for instance, the new depression drug, desvenlafaxine, also called Pristiq, was really studied on under 300 patients for a year. So they disguise this by talking about patient years. If you have 300 patients that are studied for 1 year, then each of those counts as a year. So what they call it is we have 300 patient years. That's real different from 300 patients for 1 year, isn't it?
Right.
It sounds a lot better. It's been studied 300 years. So, drugs are getting past the FDA in very select populations where the drug company itself is the one that's gauging, is this a side effect of the drug, or is that not a side effect? So you're just asking for the company that obviously stands to profit is the one that gets to determine how safe and effective its drug is and presents this data to the FDA. You complicate that by the fact that FDA advisory committees are stacked with people who are or have been in the pay of drug manufacturers, usually in the very specialty type drug that they're looking at. And even though there have been recent revisions in the guidelines of who can serve on an FDA advisory committee when these things are being voted into existence as to whether the drug is approved or not, you still have abundant exceptions to the point where some people have called the reforms just completely useless and just window dressing, and nothing actually has changed.
So we can't really count on the FDA to ensure that our drugs are safe, huh?
No, absolutely not, but luckily it's being increasingly recognized, and in fact Senator Grassley has been having an ongoing congressional investigation into inappropriate representation at the FDA, but some have called the FDA simply a revolving door for the drug companies. It looks really good on your resume that you worked at the FDA for a couple of years because you're going right to, a high position at one of the top 10 drug companies. And the only way to get that is to be, very friendly toward the FDA, toward the drug companies while you're serving public service. There are some exceptions. There was recently a report in the past couple weeks of scientists within the FDA raising a mutiny, saying that there is such shoddy science and there's such a willingness to ignore important drug data that that they feel like they couldn't any longer ethically do their jobs. So there's starting to be raised awareness and increased accountability, but it's an uphill battle. It's a slow go. FDA approval simply means that the studies that the drug company submitted to the FDA, that the panel full of conflicts of interest approved, says that we think it's safe enough, and effective enough to be let out into the general population, which, as I mentioned earlier, is essentially a phase 4 study. Now that it's out in the population, we're going to see what it really does. Sorry if you died.
Mm. And you can't sue us until now.
Until now, the Supreme Court decision just today says that the drug companies were trying to argue that if their drug was FDA approved, then you couldn't come back and sue them because, after all, an arm of the federal government said it was safe and effective. And that went all the way to the Supreme Court, and that got shot down today. No, you can still sue even though it was FDA approved. And as I showed you with that impressive list of drug recalls, these drugs are FDA. Most of them are FDA approved. Most lawsuits aren't from inappropriate or unusual use of a drug. They're due to drug injury that occurred when a person was using it strictly according to how the FDA approved it.
Mm-hmm. Mm-hmm. Well. JC, are you on the line? I'm sure you have a lot of questions to ask Dr. Dolan. Excuse me. JC?
He might have himself muted.
Okay. All right. Well, let me ask another question while we're still working on him. Now, at the beginning, you were basically talking about having the need to have doctors be able to inform their patients of the pros and cons of the drugs. How practical is this, really? Because
well, again, doctors may claim, hey, we're under an HMO system, managed care, all that. We don't have time. But the typical doctor really only, like I said, that's why I boiled it down to the top 25 interventions. The routine tests that they recommend, colonoscopy, mammogram, PSA testing, the routine interventions, a flu shot, antibiotics, antidepressants, stomach medications, a couple high blood pressure pills, some cholesterol-lowering drugs, stuff for arthritis and pain. When you basically get into those categories, it's a relatively small number. And if any practicing physician just really does a little survey and just keeps a little hash marks for what they do over the course of the week, they can rapidly see a pattern emerging, and they'll find out that they give 25 or less, they offer 25 or less routine interventions. And if they really, take the time to do their homework on those 25 things that they're routinely recommending or offering or requesting of their patients, and get to the point where they can really give informed consent. It need not be burdensome. It doesn't have to be extensive. It doesn't have to be long. And I dare say that any physician who really does this is going to start to change his mind about the things he more routinely does. I'll tell a little telling story here. When I was getting my training back in the early 80s, I was under the tutelage of some internal medicine physicians that I really admired, and they were really well liked by their patients, and really wonderful doctors with good bedside manner. And this was at a time before Motrin was available as an over-the-counter drug. It was strictly prescription at that time. And one of my mentors said, my son just had a football injury and had an ankle strain, and I was going to go ahead and give him some Motrin, but I took the time to read in the PDR, the physician's desk reference, about all the side effects, and oh my God, the incidence of bleeding ulcers when you take that medication is just incredibly high. Now, he gives this drug 5 times a day in his practice. And I remember hearing him say this, and me, poor idealistic little medical student, I was just crestfallen because I thought, don't you read the PDR for your own patient? And unfortunately, this is all too common, that doctors are not doing what they went to medical school and were trained to do, which is to look at what's the best interest for the patient. Okay, maybe we're not first doing no harm, but what about the Hippocratic Oath of, not giving a deadly drug, or at least realistically and scientifically evaluating the potential risks and benefits, and then informing the patient of that so that person can make his own decision. It just came out in the news that the drug to decrease the clotting of the coronary arteries, Plavix, is associated, when that's given after a heart attack, it's associated with a huge risk of stomach ulcers. So those very same people then have to be on a stomach medication. Well, it turns out some of these medications that inhibit the stomach acid, when they're given with the Plavix, when they're given together, they cause an increased risk of a subsequent heart attack. So it's kind of like, wait, what's the whole goal here? Maybe a person should just be on a little bit of baby aspirin and they could take a little antacid. However, aspirin and an antacid are generic. There's no drug company pushing them. There's no commercial for them.
Right.
But for a doctor to do just the very most, the briefest review of the literature on his 25 top interventions is not too much to ask. It will become very routine for him. He could make up drug information sheets. Unfortunately, like I said, it's very hazardous to go to the web to look up drug information. One of the most popular drug information sites is WebMD. And in some of their sites, you roll your cursor over the word cholesterol and you get a pop-up ad for Lipitor. It's hardly an objective site. Your essay on cholesterol is totally funded by the Lipitor manufacturer. So, you could just see the conflict of interest there. Now,
right.
My website, SmartMedInfo, prides itself on no drug company influence, but there's very few of those out there. Most of what else I have listed on here is really more directed at information sites for physicians and is more or less in lay language and may not be appropriate for some patients.
Mm-hmm. Well, speaking about your website, someone typed in a question, and JC2 typed in a question, but I want you to quickly answer this one first, and then I'll ask JC's question. Does your website deal with informed consent about testing procedures, such as needle biopsy?
Okay. Right now, we haven't branched out to that. We're actually continuing to put content on the website based on consumer feedback and looking at what people are demanding and what they're interested in. Biopsy is something that I'm going to have different answers based on the exact condition. What's the difference between how much you can trust a pap smear report versus a prostate biopsy report. Those are two different answers entirely. So they're very topic specific. The articles that we have on the website are more on topics that really illustrate the need for informed consent. So what we're attempting to do is educate the consumer in getting into the mindset of going, wait a second, what's the known safety about this? What are the known safety concerns? What's unknown about the safety? How long has it been tested? In other words, to get into the mindset to educate a person into asking the questions and demanding informed consent rather than being an encyclopedic website addressing every single potential medical situation that's out there. Because, for instance, for a needle biopsy, they're the same questions. Why do I need it? In other words, what's the indication? What are the complications of the procedure? What are the results we're going to get? Is it going to be a chance that we have to go to open surgery anyway? Why should we mess with the biopsy? What's the false positive rate? What's the false negative rate? They're really, to a large extent, the exact same questions, whether it's a procedure or a medication. What's known and not known about the safety? So, for instance, a biopsy of the lung carries the hazard of potentially collapsing the lung. You should say, well, what's the risk of that? My own mother was now advised to get a lumbar fusion in her low back, and the doctor really sold her on how this was really going to help her. And he didn't give her any information about what's her risk at age 76 of having the level above and the level below the lumbar fusion from collapsing. Said, could you please ask him that data? Now I could tell her, but to her, I'm still her daughter, her little girl, who,
Right, right.
You know how you're never a doctor to your own mom.
No, you're not. I agree.
We do welcome that people write us at info@smartmedinfo.com, and they could, it would be very useful to get some questions as to see what people would like addressed on our website, and that's the address for people who are making inquiries as individuals. Right now, our website is more directed toward companies. We really are encouraging companies to enroll their employees in SmartMedInfo website so that they can have access to informed consent anytime they get a prescription. We're really have data that really supports the idea that if a person was truly informed along all these points of informed consent, that they would be making very good decisions regarding to accept or reject a particular medication. And any medication that was truly essential, they would probably have better compliance to taking needful medications. But when we look at a 71% increase in the number of people on medications in a time period where the population only went up 9%, we are, quite certain that if people avoided unnecessary medications, that health insurance costs would go down, health care costs would go down, wellness would go up, and drug adverse effects obviously would go down. So it would be overall, good for the company, let's say. What's good for the individual in this case is what's good for the company.
Right.
But individuals can certainly ask us to address certain things by just emailing us at info@smartmedinfo.com.
So you have people who would answer questions on an individual basis?
Well, what we would do is when we get a certain number of requests for a certain topic, we'll go ahead and write what we call a lowdown article on it, basically an in-depth article going, for this particular topic, what would true informed consent look like?
Okay.
Or for this particular drug, yeah.
That's good. That's good. All right, JC's question. What are black box warnings?
Okay, black box warnings are warnings that appear at the very front of a drug information sheet, a drug, what we call label, but they're obviously, like these multi-page things. For instance, for Effexor, the drug information, the package insert is 56 pages long in 6-point font. But a black box warning actually is a thick black, outlined box that has prominent bold type writing in it that is the highest warning that the FDA gives short of pulling something completely off the market. So an example of black box warnings, all of the antidepressants now carry black box warnings regarding an increased risk of suicide, even in people who were not suicidal before they started the drug. Significant, up to twice the risk, twofold increased risk of suicide for children all the way through adolescence and young adulthood. It goes all the way up to age 26. Now, we know that there's no difference in the brain chemistry between a 26-year-old and a 27-year-old or a 47-year-old for that matter. But the warning stops at age 26 because that's where the study stopped. So there's a black box warning for suicide on every single antidepressant. There's a black box warning on the antipsychotic medications for an increased risk of death of all causes, but particularly stroke and heart attack in the elderly. There is some things that are severe adverse effects, but there's no black box warning for them because they're not that common, but they could be deadly. For instance, venlafaxine is the generic name of what was marketed as Effexor, has now gone generic, has on somewhere buried on like page 52 of the 56-page package insert the little warning that it can cause homicidal behavior. This is something that was not there until 2 years after Andrea Yates notoriously drowned her 5 children in Houston under the effects of Effexor. Another thing that's not noted on the Effexor labels, it can give you a positive urine screen for PCP, phencyclidine, the psychedelic, street drug. So there's some things that can be severe, but they're not necessarily black box warnings. The diabetic drug Avandia has a black box warning that it can cause fluid retention and worsen heart failure. Avandia users actually have a 43% increased risk of heart attack. particularly
Oh, wow.
if they're using nitrates or insulin. So there's a black box warning on that. There's a black box warning on the new drug Prestique that it can cause serotonin syndrome, causing hallucinations, high fever, poor coordination, nausea, vomiting, diarrhea. There's a black box warning on the diabetic drug Actos as well. So, you know, there's the black box warnings is the highest warning short of pulling a drug off the market.
Okay. Well, speaking about warnings, and boy, this is scary. Wouldn't it scare patients away from necessary medications if they were warned of all possible side effects?
Well, again, that is where the role of the doctor comes in, and that's been the argument. And I think it's a very flippant, glib argument to say, well, if you knew of everything, you know, you wouldn't even go out.
Right.
And that's not true. I mean, we know that, you know, the second killer, you know, is motor vehicle accidents. It doesn't stop any of us from driving out in our cars. But, you know, to say, I don't feel that patients are ignorant enough to be scared off of a medication. You know, just say, look, you need to take insulin for your diabetes. If it's overdosed, it can cause such a low blood sugar that it can give you a coma. But in order to prevent that, we're going to put you on such and such schedule, and you're going to check your blood sugar, et cetera. You know, I mean, you know, it's really the skill of the physician to say, look, I really think you need this. Now, when it's a drug like Tamiflu, and they're saying, you know, it carries now a black box warning regarding agitation in children. In fact, kids have actually committed suicide on the drug. Of course, the drug company Roche says, well, some children who have been on Tamiflu have fallen out of the windows of tall buildings. And all they really agreed to was a black box warning that just said agitation rather than suicide. You know, but to say, look, this can cause this, but guess what? It only reduces the symptoms by 1.3 days. So in light of that, you know, make your decision. Is this really worth it to you? So, you know, I think that, you know, if somebody's having trouble breathing from asthma, really needs steroids, yes, it can cause mania and agitation or depression. It can cause thinning of the bones and high blood sugar. But if you don't take it right now, you're going to stop breathing. I think that's pretty easy for a patient to understand and to make a decision on.
Help them be informed about, help them balance to weigh out pros and the cons, so to speak, right?
Exactly, yeah. You know, there was this recent decision, the Supreme Court decision we were mentioning earlier about drug companies can't hide behind FDA approval to escape responsibility for the dangers of their drugs. They were saying that, you know, all this stuff about drug dangers just serves to confuse people. And, you know, it's really saying, you know, we really think that the patient population is just a little too stupid to understand.
Right.
And I don't think that's at all.
Well, it's kind of reminiscent of really back to the medieval times, I mean, where knowledge was kept to a select few, and they felt that, well, they would just feed out the knowledge based on how we think that the general population can receive it. So,
Exactly.
I mean, it's just repeating itself over and over again, whether in religion or in the pharmaceutical companies or anywhere. I think it applies in every situation.
Well, I think patients have really made their voices heard through individual lawsuits, but also through class action lawsuits that, you know, we're not all that dumb. And we're starting to get the drift that maybe people who have a primary profit motive aren't necessarily putting patient welfare first.
That's good, and we should see more of that too. What do you feel about thermography in breast cancer identification?
Well, thermography, which is using a temperature differential in order to detect abnormal tissue, certainly avoids the radiation exposure. And one thing we do know is that radiation causes cancer, and it especially promotes the development of breast cancer in women who are genetically prone to breast cancer to begin with, who are the people who are really getting encouraged to get a lot of traditional radiation-based mammograms. So I think that the increased use of thermography is going to be driven by a consumer demand for it. We just have to make sure that the insurance company reimbursement is keeping pace with the knowledge that the consumer has that this is far safer and the detection can be just as good.
Great. And I warned you about this before the webinar. Someone is asking about a book. Where can we get this in writing?
I get asked about a book all the time. My chapters for the book have basically been turned into my lowdown articles on the website, and yet if anybody out there wants to volunteer to publish me, you know where to reach me, info@smartmedinfo.com. I'm just sort of too busy taking care of business and answering patients' questions in real time to sit down and write a book on it, but someday I'm threatening within the next year or two to get a book out.
All right. Well, please let us know when that happens for sure. We definitely need that information in circulation. Yep. We're going to let you go very soon, Dr. Dolan. Dr. Nolan. I keep calling Dr. Dolan.
Well, thank you so much for this opportunity. I think that, many years ago here in Austin, I had a second opinion practice where I would basically, it was just basically founded on informed consent. Like, here's what you need to know about this, and you're going to make your own decision as to whether you're going to take this. I can give you my opinion. Here's what we know and don't know about the science on the safety and effectiveness. And I found, sadly, at that time, which was about a dozen years ago, I was unfortunately well ahead of my patient population. But the consumer population has really caught up, and they are now demanding to be in charge of their health care. And the best insurance you have is your own knowledge and your own ability to make a judgment, and that's where you need to demand informed consent.
Absolutely, well said. Well said. We're just going to wrap it up right now. But Dr.